Hello everybody, welcome to the Stoke Mandeville Plastic Surgery webinar series. My name is James Chang.
I'm Rebecca Shirley, good morning.
So thank you very much everybody for joining us, and this is Dr. Tsao.
Yes.
Hello. So today I'm very humbled but delighted to introduce our guest speaker, Dr. Tsao. Dr. Tsao is an internationally recognized figure in the world of reconstructive microsurgery, specializing particularly in head and neck and esophageal reconstruction. Between 2014 and 2020, he served as the chief of the Division of Plastic and Reconstructive Microsurgery at the Chang Memorial Hospital in Taiwan, one of the premier units worldwide. And I was incredibly lucky to have Dr. Tsao as one of my mentors during my time there. And I can tell you he's a true master. His attention to detail, his technical skills, his innovative approach are second to none. Now, Dr. Tsao has a phenomenal resume. He's completed almost 2,000 free flaps, and the majority of these were related to head and neck reconstruction. He's done over 170 cases of esophageal reconstruction and 50 cases of synchronous esophageal and voice tube reconstruction. Patients who've had total laryngectomies lose their ability to speak and swallow. And these are fundamental functions of life, and therefore they suffer social isolation and a reduced quality of life. Now, Dr. Tsao is obsessed with improving the lives of these people, and there's no better person in the world to talk to us about this than Dr. Tsao. So today we welcome him on this show, and we'll learn from him about his innovative approach to reconstructing both the esophagus and the voice tube simultaneously. So, Rebecca.
I would just like to say that in my very brief visit to Chang Memorial Hospital, I was very much struck by Dr. Tsao's aura. Late at night, he has a persistent perseverance, which is extremely pleasant. And I've definitely taken something of that home with me for microsurgery practice. So it's a really great honor to have you here today. Thank you for coming. Just a few notes about the housekeeping. Please do ask questions because this talk is pre-recorded. It's about 40 minutes long, and Dr. Tsao is available at the end to answer any of your questions. So if you could ask them on the Q&A function, James and I will pose them to Dr. Tsao at the end.
Good morning, everyone. It's my great honor to be here to share my experience about speech reconstruction. I would like to introduce a good method for voice reconstruction. This paper had been published on Oral Oncology 2020. Here demonstrated the flaps we use it for esophageal reconstruction. The left side is our institution, and right side is on my hand. And focus on cervical esophagus. The first option is LT, and the second is the jejunum. Here is the summary of the options. Cervical esophagus, a segmental defect. We prefer to use jejunum, LT, or forearm flap. For patch defect, we prefer to use forearm or LT flap. And the fistula, we prefer to use petticoat, PM or DP flap. Here are some examples. The cervical patch defect, like here is a laryngeal wall defect. We can use the free forearm flap to cover the defect. And we can harvest another skin pedal for monitor or a muscle cup for monitor. And this is the result. This is a standard segmental defect of esophagus. We can use the free jejunal flap to reconstruct the esophagus defect. And this is the monitor loop, and this is the vascular pedicle. And this is the result. And this patient has been performed pectoralis major flap 2 times, but both failed, and then referred to my clinic. And we can use the jejunum to bridge the esophageal defect. And here is the monitor loop, and here is the pedicle. And also we can use jejunum to bridge the defect between the oropharynx and the colostomy. This patient had been performed pedicle colon transfer for thoracic part esophagus reconstruction, and I used the free jejunum to bridge the defect, and then the patient can resume the oral intake. And this is a long segmental esophageal defect. We can use a tubed ALT flap, and we can design longitudinally, and then the donor side can be primarily closed like this design, and then this part dipsization and the partial of the skin externalized or monitor. And this is the result. We have faced when the patient referred to my clinic, and this kind of patient are referred for salvage excision and reconstruction because of failed chemoradiotherapy and with residual cancer or recurrent tumor. And this kind of patient, after total laryngopharyngectomy, they need to sacrifice SCM muscle and IZV. And then we can see the carotid artery is open and exposure. So the carotid artery blowout may happen, and the mortality rate is quite high. Once leakage, toxic drainage, and the radiation injury may result in the friable blood vessel and increase the risk for blowout. To deal with the problem, we developed a method called delta inset side flap to reconstruct the esophagus and prevent leakage. We use a big trapezoid part, tubed for esophagus, and then another trapezoid part, dipsization, to cover the major vessel, the friable vessel, and then the distal part externalized for monitor. Because in the transverse cross-section, this inset looks like the Greek letter delta, so we call this delta inset side flap. This part for esophagus, and this part dipsization to cover the friable vessel, and this part externalized for monitor. And the pedicle and the recipient vessel can select the contralateral side, relative healthier side. And once the toxic drainage, leakage, and then the toxic drainage will direct go out from the penrose here, and then the toxic drainage will not accumulation around the friable vessel. Here demonstrated the flap design and the harvest. This is the flap, and then the inset. This part use it for esophageal reconstruction. And then here is the friable blood vessel. And then we use the deobstruction area to cover the flabber vessel. And then this part externalized for monitor. And the pedicle put to the contralateral healthier side. And here's the result. Here is the permanent tracheostoma. And the esophagus bridged inside. And here is the externalized for monitor. The complications. By using the delta inset side flap, we have found no perioperative complication require respiration, and no deep space infection, abscess, or other life-threatening complication. However, the fistula or stricture occurred in 5 cases, especially the distal side, and the lymphocyte occurred in 1 patient. To deal with the fistula and the stenosis stricture problem, we had developed a modified delta inset LT flap. We put 3 anchor sutures to advance the posterior wall of the esophagus stump. Here is the esophagus stump, and then we suture 3 stitches to pull the posterior wall advance. Like this, and then suture 3 stitches, and then the distal orifice become like big oval shape, can decrease the stricture rate, and then also can decrease the fistula formation rate. We compare 3 different inset designs, the spiral tubing design and the traditional delta inset side flap and the modified delta inset side flap. And then we found the stricture rate in the distal anastomosis was 33% in spiral tube group and 28% in the delta inset side group and 6% in the modified delta inset side group. There was a significant difference. And also we found among the 3 groups, regarding the average time to oral intake, that was shorter in the modified delta inset side group. So the conclusions, the modified refining of the delta inset side flap may circumvent distal anastomosis stricture with earlier oral intake. And this is the esophageal reconstruction. And how about the speech? How to restore it? So without reconstruction, the patient can use the external voice device to speech. But the sound like a machine, and the saliva easy accumulation inside. The patient need to shake the device after speak 1 sentence. So it's very inconvenient. This is electrolarynx, but the sound also like a robot machine. Patients, they don't like to use it in public. This is esophageal voice. Patient will develop the esophageal voice after 1 or 2 years later. However, the sound like a chicken crackle can only speak about 2 to 3 words. We had developed a J-designed side flap for speech reconstruction, which modified from our delta inset side flap design. We use this part for esophageal reconstruction, similar to the delta inset side flap. But the distal LT, the design is different. We designed a transverse tube to bridge the esophagus area and the tracheostoma area. And these two parts join together like the letter J, so we call it J flap. And this is the result of J flap. All can clearly speak 10 words in a breath, and the vibration rate of voice tube can up to 100% after training. It's similar to natural human sound. Voice tube replaces the function of vocal cords. Here I demonstrated the J design size flap for a segmental esophageal defect. This is the flap design. And then we deobstruction this area. We suture and tube the voice tube area and put a silicone stenting inside. And here is for esophagus. So this is the inset. We suture the upper part first, and then the lateral part and the distal part. Here is the inner orifice of the voice tube. Here put a stenting. And then the voice tube outer orifice was side by side inset close to the tracheostoma. And this is the J flap for a patch esophageal defect. If the posterior wall is intact, so we need only the anterior wall reconstruction for esophagus. So we design like this. And then this is the flap. And this is the inset. We suture one side first, and here is the inner orifice of the voice tube. And then we suture the upper oropharynx area, and also another side, and then the distal part. And the pedicle can put to the ipsilateral side or to the contralateral side. The phonation effect is like play a trumpet. We can use the thumb to guide the airflow into the voice tube, and then it will create some vibration and jitter sound into the esophagus and then to the oral cavity. And then the patient can speak, or they can The patient will start training the voice tube. 3 weeks later, we will remove the silicone tube and then start to ask the patient to guide the air into the voice tube and then generate some voice like O or E. And then within 1 to 3 months, the phonation will a little bit breathiness, roughness, and streaming. However, 3 to 6 months later, the breathiness, roughness, and the straining were improved. Constant air ejection through the voice tube to confirm the patency of the voice tube is important. We can use the 20 cc syringe or the 50 cc syringe to push the air into the voice tube to confirm its patent. And the speech therapist joined the voice rehabilitation once the patient can count to 10 in one breath, with vibration rate of voice tube reaching 80%.
Okay. Then start 1。好，再试说2。好，所以
Here I teach the patient to train in the voice tube. You can teach the patient use index
2。
or use the thumb. Initially, the voice will roughness and briskness, and sometimes air leak. However, after 6 months, the patient can speak well. He can speak 20 words, 2 sentences very clear. The vibration rate can achieve 90%. The roughness and briskness improved, and the fluency is quite good. And also, he can talk with his friends by cell phone. Intelligible conversation achieved. The overall voice tube function. About 70% of the patient use voice tube as their primary phonation method. 3 patients, 15%, convert the use of voice tube to external voice device, and 2 patients died. This is the raw data of the phonation and speech assessments. And we use the score system 1 to 5 to evaluate intelligibility, loudness, and fluency. Score 1 is poor, and the score 5 is excellent. The raw phonation is sufficiency, about 75%. The average maximum phonation time was 8.9 seconds. The average number of counting in a breath was 14. And about the loudness, fluency, and intelligibility, we found they were improving as time goes by. At the last review, we found the score can reach more than 4. And about the briskness, roughness, and straining, we also found it's getting better and better as time goes by. Only the pitch will stay at low pitch in some patients. This is the patient can achieve the conversation level speech. The patient also teaches me how he used the voice tube can speak better. The vibration rate can achieve 100%. The fluency is very well. This patient can also speak 20 words very clear. The vibration rate 95%. A little bit roughness and briskness. The fluency very well. Oh, this patient also speaks very well. This patient also the vibration rate achieved 100%, the fluency very well. And about the swallow function, we use this score system to evaluate the swallow function. Score 1 is poor, and the score 7 is excellent. And we found about 65% achieved the full diet, 20% soft diet, and 15% liquid diet. And this is the score. And about the complications, here is the summary of the complications. They are the esophageal anastomosis leak happened in 4, or stricture of fistula formation, or esophageal to voice tube leak happened in 9. They are the fluid leak or the full leak go out from here, or the voice tube stenosis happened in 5, and the voice tube external orifice dysfunction or voice tube prolapse dysfunction. And the tracheostoma breakdown and the stricture happened in 7, and the recurrent pneumonia happened in 2. The management of complications. The esophageal leakage happened in 4, 20%, or conservative treatment can achieve the healing. And the voice tube leak happened in 2. And early, the fluid leak from the voice tube, it's just temporary. We were observed for 1 month, and the voice tube external orifice dysfunction happened in 4, about 20%, and 3 regained the voice tube function post the revision, and the voice tube stenosis happened in 25%. 2 regained voice tube function after revision, and voice tube leak happened, fluid leak happened in 4, moderate 1, mild 3. This will just conservative management. We can teach the patient use the cotton swab to put inside the voice tube outer orifice during the intake, or use the local, use the finger direct compression the voice tube, can control this. And the full leak happened in 4, conservative treatment in 2, and the revision 2. And air leak 1, which need revision. And tracheostoma stricture happened in 7 patients, about 35%. This is a major problem. Some patients need continuous stenting, and 4 patients need revision. Stomoplasty. And if the patient, the general condition is good, and the prognosis is curative, and the tumor resection margin can clear, and the gray vessel exposure is not exposed, then we will proceed to do J-flap. However, if the condition is poor or prognosis is not good, and the tumor resection margin is positive, or the gray vessel is exposure, the carotid blowout is risk quite high, then I prefer to use delta inset side flap. And then the speech will be referred for external voice device. We have a study. We compare the speech performance between the J-flap and the external voice device pneumatic larynx. And we found the J-flap phonation tube yield an improved speech range. Either the voice range or the semitone range are both significant. And also, they have comparable label of voice handicap and speech intelligibility. About the fundamental fluency, the voice range profile, a normal man is around 120 to 1300 Hertz. And the J flap is around 160 to 900 Hertz, which is quite similar to a normal man. And compare with the external voice device, which just only around 200 to 350 Hertz. This is low pitch and narrow range. We have some patients that have early regain of the speech function with good voice quality because maybe they are young or good lung function or flap pliable, such as this patient. This is the flap design and the inset and the outcome. And then his speech. He can speak in one breath from A to Z and just post up 1 month. You can see the 3M tape still over there. And after 6 months, even after radiation, the speech very well, clear, and the conversation level, and he can sing. Compare with the other reconstructive voice. I learned the concept of voice tube from my teacher, Professor Hongji Chen. He liked to use the intestinal flap as the voice tube, such as the free ileochoric flap or free jejunal flap, or sometimes he can use the appendix to generate the voice. However, the issue should be considered. They are the bulging neck tissue, and the weak sound and the low pitch, and blow hard to generate voice, and food or secretion accumulation inside the voice tube, and will be pushed out during speech or the multiple revision. And compare with the electrolarynx. We know the sound like a robot. The patient, they don't like to use it in public. And the sound is not very clear. And some patients, they cannot generate. And the rheumatic larynx, the saliva, easy accumulation inside the tube. So you need to shake the tube after speak one sentence. And the sound also like a machine. But the sound is quite clear. And about the transesophageal valve, the so-called TEP. And what is TEP? It is a small puncture in the wall between the trachea and esophagus. And this puncture will hold the processes. And then we can close in the stoma. Can be done with finger, thumb, or hands-free valve. And this redirected the current of air will pick up vibrations as it passes through a narrow section of esophagus. So the talking is again possible. However, this device is not available in Taiwan now. This is the T puncture. The video I took from the website.
We'll try this again. Say hello. Say hello. Chin down. Chin down. That was also effective. Hello in the neutral position again. You can hear the difference.
Again, the issues about the expensive and change processes every 6 months, and granulation tissue formation, fungus infection, processes dislodge or displacement, difficult clean, and TE fistula all need to considered. We have compared the outcome of our J-flap before operation and after operation about the voice quality. This is the pre-op voice by vocal cord. It's mild roughness, mild breathiness, no streaming. This is because of the patient after concurrent chemoradiotherapy. The hypopharynx is narrow. This is the voice generated by voice tube. The timbre is similar to the vocal cord, mild roughness, mild breathiness, and moderate streaming. And after operation 6 months, you can And because of good outcome, we had extended the indication of J-flap to some patients, such as the synchronous tumor with esophagus cancer. We have done 3 cases. The synchronous esophageal cancer and the failed chemoradiotherapy of hypopharyngeal cancer. Our original method is delta inset side flap. Here is the after total laryngectomy and the removal of the interjugular vein and SCM muscle. And then the chest surgeon had to remove the thoracic part, esophagus, and then use the gastric pull up through the mediastinum to here. And then here is the carotid sheath was removed because of the tumor invasion. The median layer of the common carotid artery exposure is high risky of carotid blowout. Therefore, we select the delta inset side flap to deal with this patient. We use this part to bridge the esophagus, bridge the oropharynx and the gastric tube, and then use the defectization part to cover the friable major vessel. And this is for monitor. This is the design of flap. This inset. Here is the esophagus and the entry tube stenting. And this is the defectization zone, cover the vessel. And for this patient, we found there are no vessel, no friable vessel exposure. So we can use the J-flap to bridge the defect between oropharynx and the gastric tube. And this is the speech result before operation.
无法主体回诊，循序看诊前两日
This is vocal cord sound. And this is after J flap. The sound by J flap. Again, this is another patient. Here is the gastric tube pull up here, and then the posterior wall can connect it with the pharyngeal wall. So we can design only a patch defect, cover the anterior wall enough. And then the voice tube for speech reconstruction. And this is the result. A relative wide range of speech. So the conversation level of speech achieved. So the J flap is a new concept for synchronous reconstruction of esophagus and the voice. J flap is safe and swallowing function is compatible with other surgical approach. The speech quality and fluency with voice tube improved with vigorous rehabilitation, and the voice tube from J flap provides a wide range voice speech and clear humanoid voice. Here is the method we monitor the flap. In the care unit, they send me the picture every 8 hours. Here is the flap. We can direct the monitor to see the color and turgor. And if there are any questionable, we can scratch to see the breathing. It's pink or dark. And then the flap we can find every day is improving, and today's post-operative day 7. And this is the voice hood, and this is the tracheostoma, and the voice tube outer orifice will set about 1 to 4 o'clock aspect. Conclusion: J design side flap achieved complete reconstruction of both swallow and speech functions, which much improved the patient's life quality. Despite the challenge, majority of the patients, about 75%, achieved conversational level of phonation capacity with more humanoid voice compared with external voice device. And this option is indicative for patients planned for total laryngeal pharyngectomy. However, strict selection criteria should be followed. Thank you for your attention.
Brilliant. Thank you very much, Dr. Tsao. Congratulations, an incredible presentation, and it's wonderful to see your journey through the innovative iterations over the years, how you can now really push the frontiers and can really improve the quality of life of these patients who've been very debilitated following the laryngectomies. I think Rebecca has a few questions to start off the Q&A with.
Yes, so thank you very much. And I must say it's an area of surgery that I've not got much experience in, and it looks absolutely incredible. I'm very interested to know about how you can sense these patients and whether there are some patients that just don't want to have this voice reconstruction.
Yeah, actually the patient, some patients, they say they don't need the voice reconstruction. They can use the external voice device. It's true, but if you explain to the patient and then you show some video, the previous patient, the video to the patient, and then they will think, the voice is just like similar to before the operation. the speech quality, like the vocal cord, it's not like a machine or robotic sound. Yeah, and then they think they have the chance to achieve the good quality of the speech. So they usually they agree. And then I only explain to them, you have the possibility to do voice reconstruction. I cannot guarantee you can achieve a good function. But if you have the chance, if your major vessel is not exposure, and maybe the prognosis is relatively better, yeah, and then I will try to do the voice reconstruction simultaneously. Yeah, and then the patient, usually they will agree to do this, and also they will ask me, if possible, try to do voice reconstruction. Yeah.
Do you sometimes introduce your patients to people who've had the surgery before, so they can speak to the patients to understand about recovery from the surgery as well?
It depends. If the patients have some question or they ask to how about the outcome, then I will show some video to them. I will not routine to show the video to them. If you show the video and the speech quality to them, then you need to explain more to them. You have possibility to achieve the good conversation level, but possible you cannot get the good outcome. You can also show some video like the speech quality not so good. Maybe just even the speech quality not good. It looks like air sound, like a whisper. It still can guide the air flow in. Like we can say like A, B, C, D, E, like air sound. We still understand. The patient still can speak. Yeah. So you use the voice tube to make a shunting between the tracheostoma and esophagus. And this concept is quite good. Yeah, I learned this from my teacher, Professor Hongji Chen. He used the bowel intestinal flap to do the voice tube. Actually, this concept is quite good. Yeah.
Dr. Tsao, you mentioned about following strict selection criteria. So when you talk about prognosis, what's a good enough prognosis for you to offer this to your patients?
And the prognosis is associated with the tumor. The tumor is free and can completely resection with free margin. And so you need to discuss with the ENT doctor. Yeah, if the patient, the margin is related free and the prognosis better, and the major vessel like carotid artery will not, especially the carotid sheath is not excised, it's still intact, then I think I will do the J-flap. But until now, some patient now, because I good outcome of the J-flap, so we already a little bit extended the indication. Yeah, because I know sometimes I can use the J-flap also can cover the major vessel. Yeah, still do some additional drainage adequately to guide the possible toxic drainage leakage. The area you put some pen rolls and to close monitor the possibility of leakage. I still extend the indication to use the J-flap. Try to provide the voice reconstruction to more patients, even they have the risk of the carotid blowout. Yeah, now I have performed several cases. The control is still okay, acceptable. Yeah, no major complication. Yeah.
So just a follow-up to that question then, because previously you did the delta inner thigh flap. In terms of how long it takes to do the J flap compared to that, is there much difference?
And you know, the delta inset side flap, in my early experience, the problem is the distal anastomotic part still has some more complication, like a leakage or the stricture. And then after I modify the distal anastomosis, it's improving. So after the improving, we found that the esophageal leakage rate can decrease. If the distal anastomosis, you can make the food easy to pass through, then the esophageal leakage rate can decrease. Most of the leakage is happen because when the patient swallow and the distal anastomosis is stricture. distal esophageal anastomosis stricture and then followed by esophageal leakage. So if you can make a good distal design of the anastomosis, then you can control this, and then yeah, we can improve the outcome. Yeah, and then yeah, about the J flap is because the patient sometimes they will ask us to if possible we can do some voice reconstruction, and then some will read the newspaper from my teacher, and he used the intestinal flap to provide some voice reconstruction, and they will ask me can I do this, but I have but that usually use the intestinal flap to do the voice reconstruction. In my experience, like you need a very still the learning curve. I have tried several cases, but I cannot get a good outcome. And then I try to use the ALT to do the voice tube, like this kind concept and design. But I find it's easier to get the voice, and also the voice quality looks still also good. So I keep on continue to modify and revise it better and better. Yeah, okay.
In terms of, just so we have an idea, how long does it take for this operation? This is a full day operating?
Yeah, it takes about 8 to 12 hours to complete the reconstruction and also the tumor ablation. We do combined surgery together. Mm-hmm. Yeah, usually when we start from about 9 o'clock in the morning, we will finish it around also 9 o'clock in the evening. Okay.
Rebecca.
So you talked about the risk of a carotid blowout and making the decision whether to do the voice reconstruction. Is that a difficult decision to make?
Yes, before operation, you have no idea about how the carotid artery will exposure or not. You have no. You can only ask the ENT doctor, because the tumor excision and the design of the tumor wide excision is performed by the ENT doctor. So we can only have little information, but you can feel if the neck is a little bit frozen neck, relatively difficult. And also if you, in this situation, if you try to do the voice reconstruction, sometimes the neck, the neck skin, when they elevate, and then if you want to suture back, sometimes also difficult. Yeah, because the skin, the cervical skin flap is a little bit fibrotic change. So I need to some hyperflexion of the neck to close the wound. Yeah, and you try to think about how to say, if during the operation you can confirm the carotid artery is, the carotid sheath is intact or not, then you can I think maybe modify to use the delta inset side flap or select a more safer method. Yeah, this is why before operation you cannot guarantee the patient you can get the voice reconstruction. But intraoperatively, if you found the carotid artery is relatively healthy, not so friable, is relatively safer, then I will keep on going to do the J flap, because the design of the flap is just similar. Yeah, it's easier to change your plan. Yeah.
Thank you. We have a question from Mustafa Amma, who is an otolaryngologist. He says he's completely astonished by your talk, and he asks, do you have experience with salivary bypass tubes for tubed flaps? Salivary bypass of the saliva.
Bypass, it means that put a tube to bypass the saliva. Yeah, I think in some institution or in the literature, they mentioned about this. But in Taiwan, we have no this kind of device. Yeah, I think if it's available, I will try. But in Taiwan now, I cannot find the bypass device. Yeah, and to me, I think each stitch just meticulously and fine suture to confirm is that there is no leakage after your suture. And then I put additional the stent tube to the cervical area here, and then we push some dye or you use aqua beta iodine to confirm there's no leakage. You can inflate the fluid in here and then make the inflated the flap and then to check the leakage. This is important. Yeah, initial must be no leakage. And then and then in the following, is there any saliva accumulation inside? It will be okay. Yeah.
So how soon after post-operatively do you do the imaging to check with the dye?
Yeah, the image for esophageal gland, I will arrange about 2 weeks later.
2 weeks.
Some patient, if the tissue quality is good, like no concurrent chemoradiotherapy, no history of this, then I can earlier to arrange esophageal gland about 10 days after operation. And then if I confirm there is no leakage, I will let the patient start to sip water for 1 day, and then liquid dye for another day, and then soft dye, and then full dye. So just if there's no leakage, 4 days later, the patient can eat full diet. Yeah.
We have a question from Pericles Foroglou, I hope I pronounced that correctly, from Greece, which is about the time between initial voice reconstruction and the return of the full voice use. What is there a time which you would say it takes for the full result of the surgery to take place?
To achieve the conversation speech, or I'm not really understand it from the times from initial
after the surgery. Yeah, after the surgery, how long before they have the full use of the voice? How long does it take for them to develop?
How long did it take? It depends. Some patient, yeah, just as I show one patient, that even after 1 month, the patient can speak very well. And most of the patient, they can speak well about 3 months later, because the initial 3 months, they can just train in a little bit, the generate some single voice, and then teach the patient to generate a voice. If the patient cannot generate good vibration, sometimes just only air sound just like a whisper. So you need to teach the patient how to make the vibration. And sometimes you can use additional finger to push on the voice tube. And then you can generate some vibration. If initially this is no vibration, you can push here and then make it vibration. And then teach the patient continue to learn how to use the voice tube. And then, yeah, the patient can speak well, usually after 3 months later.
How soon after the surgery do you start the training?
Start the training after 3 weeks. Yeah, I will remove the stent and then start to teach the patient. Just in the slide I show, you can teach the patient use index, or you can teach the patient use the thumb. So it depends on the voice tube, the direction. If the voice tube this direction, maybe you use the right hand. If this direction, maybe use the left hand. And then, yeah, or use the index. And so the design of the voice tube, the outer orifice is quite important, because it is associated with how to guide the airflow into the voice tube. Yeah, so you need some more tissue. I call this is voice hood. Voice hood needs full of the tissue. Then when you guide the airflow in, it's easier. Yeah, then the patient easier to train in the voice.
Okay. I have a question about the complications, because you mentioned that the tracheostoma stricture is can be a problem. So I wonder whether that is more to do with the radiotherapy than the reconstruction itself.
Yeah, because if the patient is a fresh case, the patient still need radiation after operation. We have some patients, initially we designed the tracheostoma is adequate size. However, after radiation, it becomes stricture, and the stricture we are getting worse very quick. Yeah, so because the patient, if he want to use the voice tube, so then it's difficult to use the Teflon like the stenting. So yeah, when the patient need to use stenting, then the patient lost the chance to speak. But the stricture is still a big problem. So some patient, if the stricture getting worse, if the diameter smaller than 9 millimeter, I will ask the patient start to use the stenting tube. I will use the endo, the endo tube to cut a shorter endo tube, and then just ask the patient he can put it stenting during the nighttime, and then at the daytime he still can use his voice tube.
Okay.
Yeah.
But does that mean now for the patients that you know will have to have radiotherapy afterwards, do you design the orifice to be larger?
Yeah. Now I will depend on the patient's condition. Yeah, if the patient is no radiation history, then I will design the tracheostoma bigger. For possible, maybe the patient need post-op the radiation. But if initially you design the trachea, I have several patients, 2 patients, I designed the tracheostoma bigger, but finally the stomach cannot guide the airflow to the voice tube. So, but I still can ask the patient use a cap. You can teach the patient use a cap, and then can guide airflow into the voice tube. Or you can ask the patient come back to revise the tracheostoma. Yeah. So stricture or the bigger also the problem, both the problem.
But ideally, your what diameter are you aiming for?
I think 2 to 2.5 centimeter. The diameter 2 to 2.5 is the best. So if the patient no radiation history, and possible post-operative radiation, I will design them 2.3 or 2.5 if possible. I make it bigger. And if the patient had previous operation, previous radiation, I still make it still also 2.3 or at least 2. Yeah, because the patient had previous radiation history, the trachea already a little bit smaller. So you still need to release the trachea in some patient. Yeah. If you try to make it bigger, however, sometimes you still have no chance because the trachea size already fixed in some patient.
Okay. And is there ever problems with leakage through the voice tube?
Yeah, the voice leakage is different with the esophageal leakage. Voice tube leakage. Yeah. Voice tube leakage means that when you eat, when you drink water, the water or food will come out from the voice tube and then leak around the tracheostoma. And however, we have no much the complication about the aspiration pneumonia because we designed the voice tube is the voice tube outer orifice is faced outside. So once the water leak or food leak, it will leak outside. It will not go into the tracheostoma. And so the patient just clean here. It's okay. And just a little bit in aspiration, he can cough out. And if the leakage is relative a little bit severe, you can teach the patient use a cotton swab, just put it in, and then during the intake. And then after the intake, you can remove it and clean the voice tube. So if the voice tube leak severe, then I can teach the patient like this. Or if the patient just want to drink water, you can teach the patient push on the voice tube, and then the patient can drink. And then he don't need to put the cotton swab inside the voice tube. And because the voice tube will getting a little bit shrink as time goes by in the first maybe half year, 6 months. So some patient, the initial is voice, the food will leakage, but it will improve as time goes by. Yeah, most of the time, the patient, when the patient can swallow smooth, then the leakage of from the voice tube can improve. Okay.
So Rebecca, have you got any more questions?
So there is another question from Pericles about the financial burden of the surgery. Is that a problem in Taiwan, doing these big operations that take a lot of time and need quite a lot of therapy afterwards? The question is about the financial burden.
Oh, financial. Yeah, in Taiwan, I think now that this surgery is the insurance cover, can cover the operation. Yeah, so in Taiwan, especially the oral cancer or even laryngeal cancer, hypopharyngeal cancer, all covered by the insurance. So the patient should pay only a little, just maybe about 10% of the charge. So it's okay for them. Yeah.
Doctor, I have one final question, if I may, which is that I know you're always thinking how to improve and how to innovate and how to make things even better. To you, what is your biggest challenge now, and what are you hoping to achieve with your next innovation?
Next innovation. I think, yeah, I think maybe possible in the future if I can try the patient did not perform try to not perform the permanent tracheostoma. If we can reconstruct the trachea in the future, if possible. Yeah, but I think this must be need to combine with the trachea tissue engineering. If I can do some trachea tissue engineering in the future, maybe I will think about in the future, maybe can connect the trachea from here to the maybe nasal cavity, nasopharynx area. Yeah, maybe this is in the future possible we can achieve.
Great.
Yeah.
Always good to think.
Well, this is interesting. Yeah.
Well, thank you so much. Once again, it's a real honor to have you on our webinar series. We've all learned so much, and the audience.
Yeah.
Thank you very much indeed. Incredible topic. And yeah, please do keep innovating and come back and speak to us again about the trachea.
Yeah, you are welcome. I'm glad to share my experience to all over the world. Okay, and you too.
Thank you. Take care. Stay safe.
Take care. Yeah, thank you. Bye-bye. See you.